I try and spend a lot of time. I usually spend 30 to 40 minutes with the patient, making sure that they really understand that. And by the end of the talk, I tell them, you need to know what's in my head about the drugs that you're going out. And if you do that, you're going to feel empowered to take care of yourself. And I found that that approach works really well with them. And I kind of summarize the same things in the same transitions of care note that gets routed to the provider. So again, it's more than just this, we started this medication. We started this medication based on the evidence from this trial, include the citation and reference, and kind of send that note along to the outpatient doc.
Welcome to the Pharmacy Quality Solutions Quality Corner Show, where we believe that quality measurement leads to better outcomes. Let us become your go-to source for all things related to quality and medication use in healthcare. We will hit on trending health topics as they relate to performance measurements and find common ground for payers and practitioners. We will discuss how the Equip platform can help you with your performance goals, and we will also make sure to keep you up to date on pharmacy quality news. So buckle up and put your thinking cap on. The Quality Corner Show starts now.
Hello, Quality Corner Show listeners. This is your host, Nick Dorich, and we welcome you to the PQS Quality Corner Show. If you listened to last week's episode, we had on Lucy West, heart failure and heart transplant clinical pharmacist at Cleveland Clinic, talk about transitions of care for cardiovascular disease patients. We will continue our heart health theme for the month of February since it is American Heart Month. But before we introduce our next guest, let's provide a little more context about American Heart Month. Cardiovascular disease is the term for all types of diseases that affect the heart or blood vessels, including coronary artery disease, like clogged arteries, which can cause heart attacks, stroke, heart failure, and peripheral artery disease. More than 800,000 individuals die of cardiovascular disease every year in the United States, which equates to about 1 in 3 deaths. Recently, the President of the United States has even noted at the beginning of this month that heart disease is still the leading cause of death in the United States, affecting all genders, ethnicities, and races, but it is also one of the most preventable diseases. And that comes with better education from our community pharmacists on health, wellness, and prevention to address this disease. That leads us into our conversation with today's guest as we get to speak to a clinical pharmacist from the UNC Medical Center, that being Prashanth Iyer. And Prashanth, welcome to the Quality Corner Show.
Thanks so much for having me, Nick.
Well, Prashanth, it's exciting to have you here, and I have a feeling this is going to be a fun episode as we learn more about your role as a pharmacist in a hospital setting. And we are going to talk a little bit about the end, about another interesting journalistic endeavor in which you partake, but that's a little tease before we get to the real talk here in pharmacy. And can you give me a little bit of information about your background, what you've done in your pharmacy career, and what you do currently at the UNC Medical Center?
Yeah, sure thing. So I graduated pharmacy school back in 2015, graduated from the UNC Eshelman School of Pharmacy, been a Tar Heel my whole life. And so I stayed on for my general pharmacy practice residency at UNC Medical Center, and then subsequently did my cardiology rotation there as well. And then after finishing up my cardiology residency at UNC, I left for a year. I went up to actually West Virginia University and worked up in Morgantown at Ruby Memorial Hospital up there as they were starting to build out a new kind of heart failure service that was going to be involved with LVADs, heart transplants, things of that nature. And after about a year of helping them get that program all set up and running, I decided to take a job to come back to UNC Medical Center and have been practicing as one of the general cardiology pharmacists for the last 2 years there.
Excellent. Well, with this podcast recording, I do hope that we make true of the Michael Jordan statement, the ceiling is the roof, in terms of the quality of content for this recording and the information you're going to help provide for us today. And Prashanth, thank you for that introduction. And before we jump into the context of our show, I'm going to provide a quick overview of what comes next for the listeners. There are 3 questions that we have written down to explore. I'll go down the list and ask the first question. Prashanth, you will respond, and we'll have some back and forth to summarize those key points. We're going to repeat that process for the second and third questions, which will wrap up our primary content for this episode. When we get to the end, as I already teased, we're going to have a little bit of a fun closing and summary to further know Prashanth. So with that, we're going to go ahead and jump into question 1 for today. And with this episode, really want to focus on heart health and how we as pharmacists are appropriately treating patients. I think because of this content, both pharmacists and student pharmacists, and probably even some pharmacy residents that are out there, are really going to enjoy this information. Prashanth, with your work at UNC, you do work with student pharmacists. You're working with residents. I know you've got a role with the residency program at the UNC Medical Center. Your bio on the website talks about an emphasis on clinical guidelines and primary literature regarding the care of patients, and particularly those with cardiovascular disease, and that's with the intent to optimize their medical management. From your perspective, what exactly are you providing in terms of that information to both the patient and to the outpatient providers that may be assisting to take care of that patient once they leave the hospital facility? To what extent does your reliance on updated clinical guidelines and primary literature drive your communications?
Yeah, that's absolutely a great question. And so I'll tell you a little bit about what I do at UNC Medical Center. And so I think first and foremost, I've kind of taken it upon myself, along with my colleagues here, to really do the best job we can to stay up to date on new literature. And that's, providing journal clubs every month, making sure that we're sharing articles, resources, things that we come across, so that everyone's kind of on the same page with what's updated. We make sure that our in-house clinical guidelines are updated on an annual basis, with each guideline being reviewed at least every 3 years to, again, make sure that someone is taking a look at something to make sure that everyone is still agreeing with what information is contained within the guideline. But how that really gets passed on to our patients and the outpatient providers is, I think, first and foremost, on interdisciplinary rounds. Our cardiologists at UNC have kind of become accustomed to relying on us to help them provide evidence-based care for their patients. And so in my kind of experience working there, I think they do an absolutely outstanding job with kind of almost turning over pharmacologic care to us, in a sense, where it'll say, hey, this is kind of the clinical condition we've got for this patient. What medications do you think are right here? What medications do you think we should be adding? And it's really practicing at kind of the top of your license with the most up-to-date evidence, and having the buy-in from the physician support there to make sure that our patients really get the best care possible. And so, then as we pass that on to the patients, every patient that comes through our hands, we do the best job we can to make sure that, number one, we counsel them on all new medication changes that are made. And, that process for us involves going into the room, spending some time walking them through how each medication interplays with their disease state, why we've selected it, kind of the pros and cons, making sure that the patient has a really solid understanding of the risk-benefit profile of the medication that's being added. And ultimately, they feel empowered in their medical care because they understand why the decision was made and what this medication is doing for them. Beyond that, we try to pass that same information on to our outpatient providers by ensuring that we provide a warm handoff. And so with the physicians, they'll write their discharge summaries. Those get routed to the same outpatient providers that they're going to follow up on the patient. We will also actually write our own transitions of care notes that document the pharmacologic changes made, why or why not something was done, whether or not we explored a particular treatment but didn't have the opportunity to start it inpatient, and we would like the provider to consider that on the outpatient setting. All of that gets routed, in addition to the discharge summary, to those outpatient providers. So ultimately, I think between those two things, we've tried to do a really good job in making sure that, number one, the patient understands what they're getting, why they're getting it, and they're getting the best care possible because our cardiologists have kind of enabled us to be able to assist them. And then in the second manner, we're providing that same information to the outpatient doctors that are going to follow up there to make sure that nothing gets dropped or nothing gets missed.
Before we go to our next question, I want to tease out one little item for us. And you talked about, for the institution, looking at clinical guidelines, and specifically, well, maybe we'll look at it specifically for cardiovascular disease. Is there one journal, one entity, one association, et cetera, that is the gold standard for these items? Or are there kind of competing groups that may have appropriate clinical guidelines? Where are you going to? Can you talk about where? You mentioned the when and the timeline for those updates, but would like to dig into that a little bit further before we proceed.
Sure. I think amongst our colleagues, there are certain journals that are maybe a little bit better for some things versus another. So, you mentioned having Lucy West on kind of JHLT or Journal of Heart and Lung Transplantation. That's going to kind of be the foundational journal that you're looking at. So, anything that our guidelines relate to heart, lung transplant, LVADs, things along those lines, Impellas, and whatnot, we'll pull that information from there. Kind of general cardiology stuff, we've tended to rely on JACC or the journal for the ACC. And that's because they do really nice jobs with state-of-the-art reviews, making sure they have the guidelines. But I think kind of right now, a lot of the important clinical guidelines that come out are really unified across a number of bodies. You look at the hypertension guidelines, you look at primary prevention guidelines, they've got the stamp of the ACC, AHA, and basically all these other organizations. So I think that's been the nice aspect over the last few years, is really seeing these unified guidelines come out, as opposed to, looking at the CHEST guidelines for PE and then looking at, another, the Journal of Hemostasis and Thrombosis and looking at their guidelines. We've kind of had a nice unified organizational approach, I think, in cardiology the last few years.
Great. Thank you, Prashanth. Let's move to our next topic and clinical guidelines and those warm handoffs that you referenced. With last week's episode, speaking with Lucy West about managing a patient being discharged to the community, that was really a focus on what's the short-term goals that are there. But thinking more long-term, and when you're talking with the providers and with the patient, there is an aspect of it that is just acute, what needs to happen in the next couple of days, week, and then a month for that patient that is discharged. But what about long-term? What do current clinical guidelines tell us about long-term goals for patients with cardiovascular disease, and how are you reviewing that with a patient?
Yeah, that's a great question. So I think on my service here at UNC, probably the two most common disease states I encounter are going to be acute coronary syndromes or myocardial infarctions, and then patients presenting with heart failure with reduced ejection fraction. And I think right now is a really exciting time to jump into cardiology, because the way we viewed short-term and long-term management of both of these conditions has, I think, dramatically changing and is going to continue to change. What was once kind of let's start this initial treatment, let's see how the patient progresses. If they slide, we'll start to add this stuff. And then if they slide again, we'll consider doing this, is now really being rolled into, we should be doing as much as we can up front for these patients, and really trying to avoid having kind of things to add in that long-term picture. So, an example of this is heart failure with reduced ejection fraction. The traditional kind of approach has been start your ACE inhibitor, start your beta blocker, kind of titrate those up to max dose. And then, within 6 months, try to get onto, your spironolactone or eplerenone. And then afterwards, trying to get to your SGLT2 inhibitor. Now there's kind of been this renewed focus from our standpoint to try and get actually all of that done up front, and then minimize as much in the way of long-term need for medication addition. Because I think one of the things we've identified here is when we start to rely on those long-term follow-ups to be the reason or way that these patients get on meds, you fall into this habit of clinical inertia, where potentially in the outpatient setting, some of these providers don't have as much information on the patient. You get one set of vitals, you get one heart rate, one blood pressure. You may or may not have a weight. The labs may come back after the patient leaves. So we've tried to minimize what's needed there. But really, one of the key things we've tried to do, again, for those that we can't optimize everything on up front, is we've started to implement kind of a pharmacist clinic in that long-term setting to assist our nurse practitioners and assist our physicians, such that we're kind of taking over the med titration to a certain extent to help the physician stay on top of kind of the rest of the long-term follow-up. So it's kind of a tough answer to your question, in the sense of our goal is minimize the number of things that actually have to be done long-term. But if there are things that need to be done in that setting, we've kind of added this clinic in there to take over some responsibility.
Yeah. So Prashanth, when the general public thinks about pharmacy or medication use, there's a perception that, well, the pharmacist wants me to take more meds or wants me to take my meds all the time. And it's important to point out that a good pharmacist, and I think we all are good pharmacists, we want the patient to take the minimum amount of medications necessary in order to treat the disease that they are dealing with, and of course, to mitigate any side effects that are there. Now, when we're talking about patients with some severe cardiovascular events like you've described here, that could be a big transition for patients because they could be folks that are maybe they're taking one or two medications or just a low dose aspirin and a medication to treat seasonal allergies, but suddenly they could be discharged with not a handful of meds, but likely 2 handfuls of medications that they have to be taking daily. What's that part of the communication with them to get that patient and their providers to understand, hey, this is going to be, for lack of a better term, it's a bolus of many medications up front, but if they're able to take care of themselves, that hopefully can wean them off those medications long term.
Yeah, so that's an absolutely outstanding point because nowadays you walk into the hospital, you have a myocardial infarction, and now you're walking out with aspirin, a P2Y12 inhibitor, a high intensity statin. Potentially you're leaving on ezetimibe. Potentially you're being worked up for a PCSK9 inhibitor, beta blocker, ACE inhibitor, you name it. There's so many meds you can walk out with. So usually our approach here, again, like I mentioned earlier, is we try to make sure we counsel every single patient that comes through our hands. And the approach with counseling is not simply just reviewing, this is the drug, this is the dose, this is how you take it, side effects. What I try to do specifically is I kind of walk into the room and I say, look, you came in, you had a heart attack. I walk them through their kind of condition in the most basic terms that I can. And then I kind of stop them and say, there's a lot of meds that are going to be new here, but we're going to walk through what every single one of these is doing for you. And I'll group them and I'll say, okay, you presented with a heart attack. Your doctor took you down to the cath lab. They placed the stent. This is what a stent is. This is the potential complication of a stent. So these are why you're going to leave on an aspirin and a P2Y12 inhibitor. And then, the process of, coronary artery disease and talking about lipid management. And this is where your lipids are right now. This is where we want them to be. We think we can achieve it with just the high intensity statin. So that's why you're going to leave with that. And it's kind of walking them through in that sense of understanding why the decisions were made. And then ultimately at the end, if there are kind of scenarios where we have to walk them through the risk benefit scenario, I'll do that as well. So, potentially you have a high risk stent placed in your left main and the physician's really worried about it. So they want you to go out on a short period of triple therapy with an anticoagulant plus 2 antiplatelet agents. I'm going to walk them through saying your bleeding risk, may be as high as 20% in the first 30 days, but this is the risk, that the physician is kind of thinking about when they want to make sure that that stent stays open. So I try and spend a lot of time. I usually spend 30 to 40 minutes with the patient, making sure that they really understand that. And by the end of the talk, I tell them, you need to know what's in my head about the drugs that you're going out. And if you do that, you're going to feel empowered to take care of yourself. And I found that approach works really well with them. And I kind of summarize the same things in the same transitions of care note that gets routed to the provider. So again, it's more than just this. We started this medication. We started this medication based on the evidence from this trial, include the citation and reference, and kind of send that note along to the outpatient doc.
Excellent. Thanks for that response. And with that, I'll now move us on to our third question and talking about hospital readmissions and communication. For the Quality Corner show, we like to have a focus on quality improvement in healthcare. So I have to make sure we address this one specifically. It's about preventing avoidable events. Lucy last week did a great job of talking us through about some of their quality improvement efforts, and there's regular routine meetings about how they improve quality, because when you're treating that patient, you're not thinking about your readmission rate at that point, right? But there is a point in time later where you're going to look at those different steps. So going further from what you had already explained, working with the patient or their caregiver, items that you're communicating to them and then to the community pharmacist, do you mind expanding on what is really kind of top of mind and how you identify key points where you have to pivot more to point A, point B in speaking with those patients about how they are going to be meeting clinical guidelines, not just right here, right now, but long-term for their support and management?
At UNC, I think one of the things we've done is we've kind of identified, all right, we continually will look at our readmission rates. We'll look at our case mix index to see kind of the severity of patients that we're dealing with. And then at that point, it comes down to, can we identify the barriers that are not letting us bring these numbers down? Like what is what kind of stands in our way here? Is it the patient was on a non-cardiology service, never had a cardiology consult, and therefore never kind of touched our hands, and that's why that readmission happens? Or is it, there's not enough medications in the order set pathway to get people to think about those, and maybe that's the manner that we need to go to? So we have kind of a heart failure pathway team that's comprised of a lot of cardiologists, our heart failure nurse practitioners, a couple pharmacists, myself included on that. And we meet, every week to really talk through this is what we need to do in order to get better at preventing these readmissions. We need to make sure that there are certain triggers in place in our EHR that trigger a team to consult a cardiologist if they're starting to use, higher doses of a diuretic, or there's certain things that'll trigger education from our standpoint, like a number of medication changes made that ensure that somebody is coming behind to talk to the patient about those changes. There's kind of a review of our overall order set to make sure, is the order set conducive to making sure all the proper metrics are being hit on admission and discharge for each patient. So those are things that we're trying to review on a weekly basis to make sure that at the end of the day, we can do the best job we can to take care of these patients and really keep them out of the hospital.
Excellent. Well, appreciate that commitment and your description and to how that becomes a long-lasting part of your process, right? You are absolutely treating each and every patient that comes in and considering the guidelines, you're considering that patient and what's important to them. And it does have to be a mix, right? If we're just following the clinical guidelines each and every single time, that may not be the best approach, for that patient. So there does need to be a little leeway, and it's important that the team understands that. And thank you, Prashanth, for explaining it as such. And with that now, I will get to our closing and our wrapping. And Prashanth, really do appreciate your insight on our clinical topics and speaking about clinical guidelines, how your team gets informed, stays informed, and how you communicate to community pharmacists and other providers who are going to be receiving that handoff for transition to care with the patient. Now, we have talked exclusively thus far about your role as a clinical pharmacist at UNC, and thank you for your work on that. And know that you're working quite a bit with students and residents to help educate the future pharmacists. And that's an essential part of our profession. But now we're going to transition to another topic, and it's a fun one. And it looks like you're pretty popular in this space, and perhaps even I don't know if it's the right word, amateur or maybe even professional hockey journalist on the side. So we know pharmacists are busy, but you're doing a lot more than even just being a pharmacist. And this part pains me to say out loud, but we are speaking with a Detroit Red Wings fan, apparently. Do you mind explaining that? So you're a big hockey fan in addition to being a pharmacist, which is great, but you do all this other work. What's that like? What got you into it? And to you, what's the importance of a pharmacist having non-pharmacy hobbies?
Yeah. So for me, I grew up in Detroit and I lived there until I was about 15 years old. And then when I was 15, I moved down, and that was actually right after I'd finished my freshman year of high school. So really difficult time to move from Detroit. And, again, growing up there, the Red Wings had won basically every Stanley Cup, or were competing for every Stanley Cup every year. So it was hard not to just become a diehard fan. But from there, I moved down to Charlotte, North Carolina. And, at the time, hockey's not super big in Carolina. There's not really people that I can talk about the games with every day. So I had to find some sort of outlet where I could connect with people and really talk to them about hockey, because there just wasn't that same exposure in my everyday life. So I started an outlet towards blogging, and initially I just kind of made my own blog and would, write occasionally. And I always had this kind of analytic approach to things where I wanted to really dive into the why behind stuff. So I started to write a little bit more and more. And then it's, as I was in pharmacy school was really when it started to take off, maybe 2011 or 2012. One thing I like to do is build mathematical models to, analyze different things. And I'd actually built a win probability model for the Stanley Cup playoffs that actually predicted every series correctly back in 2013. And that's kind of when everything really took off. Because then at that point, I was given the opportunity to write a guest post for the Washington Post. I was given the opportunity to write for SB Nation. And then later I wrote for The Athletic. And then now here we are in 2021, and I host a podcast for The Athletic twice a week. And I'm not really sure how quickly we got here, but it happened really fast. And so to get to the final part of your question about, why is it important for a pharmacist to have this? Well, I think in today's age, there's a lot going on. Everyone's got a lot to do. And I think the personal responsibilities maybe are far greater and a lot more complicated than really they were 30 years ago. What you have to do at home and what you have to be able to do to take care of your family, and even just simple tasks like, paying bills, buying houses. It's just a lot more of a complicated process. And so what I truly believe is you have to find a way to separate work from home. And there has to be some way to maintain a balance. I preach it to the students and residents that I precept that, if you want to turn your life over to your work, it's the person who's going to end up sacrificing at the end of the day is yourself. And so hockey for me was the one thing I had to maintain in order to help me remember that even as a resident when I'm working 80 hours a week, is if I still had this, I could have that separation. I could turn my brain off and turn it on to something else. And so I do believe it's important to maintain something, some hobby, some skill, something you like to do outside of pharmacy that, almost keeps you grounded and away from that 100% work mentality.
Yeah, thanks, Prashanth. I certainly agree with that, especially for someone like yourself who's in a hospital setting, right? 99% of your time you are spending it around other healthcare professionals. So it's very easy to have some tunnel vision there on what you're thinking about. And yes, you are speaking with patients day in and day out, but having some other hobbies and being around other people that helps to broaden our scope, helps to have a better understanding on what matters to people. And ultimately, while talking hockey, may not directly relate to patient care, it helps you to better understand people and things that they care about. So that provides a great reference point. Before we close, I've got one final question for you as it relates to this in hockey. The Detroit Red Wings, very famous for their involvement with the octopus. Does the Seattle Kraken, another sort of octopus-related creature, are you worried that they may steal some of that octopus-related hockey action from the Detroit Red Wings?
Yeah, I mean, this is going to be really interesting. We're going to have some cephalopod wars or something going on now, stuff I wasn't really anticipating. So I'm really excited to see if they co-opt the octopus. It'd definitely be a big slap in the face to Red Wings fans for sure.
Well, thanks, Prashanth. Appreciate that. And we'll go ahead and close. And again, we appreciate your time today to speak about cardiovascular disease and clinical guidelines. Really means a lot to us. If our listeners have questions for you related to either pharmacy or hockey, where can they find you?
I think if you're looking for questions related to pharmacy and the answers I gave here, feel free to email me at prashanth.iyer@unchealth.unc.edu. That's the easiest way to get in touch. That's my work email address. Otherwise, if you're interested in hockey stuff, you can look me up on Twitter. My handle is @Iyer_Prashanth. It's pretty much all going to be hockey with an occasional pharmacy tweet in there. So make sure you know what you're getting into before you go looking.
Great call out there, Prashanth. And again, thank you for appearing on today's show. Really appreciate it. And this certainly got into some fun conversation for us talking about hockey journalism, cephalopod wars, in addition to the cardiovascular disease. For our listeners, we're going to go ahead and wrap up, and please tune in next week as we do round out our series on cardiovascular health with talk about quality measures related to heart health. Also, to make sure you subscribe to our podcast so you'll be ready to further improve cardiovascular health outcomes or other topics that we cover. If you have a question or topic that you would like to suggest for the PQS team, please let us know. You can contact us at info@pharmacyquality.com, or you can DM us directly on Twitter @pharmacyquality. With that, I again appreciate you listening to the Quality Corner show, and there is one final message from the PQS team.
The Pharmacy Quality Solutions Quality Corner show has a request for you. Our goal is to spread the word about how quality measurement can help improve health outcomes, and we need your help in sharing this podcast to friends and colleagues in the healthcare industry. We also want you to provide feedback, ask us questions, and suggest health topics you'd like to see covered. If you are a health expert and you want to contribute to the show or even talk on the show, please contact us. You can email info@pharmacyquality.com pharmacyquality.com. Let us know what is on your mind, what we can address, so that you are fully informed. We want you to be able to provide the best care for your patients and members, and we wish all of you listeners out there well.